Hello. I would like to thank first my colleagues and my friends, Dr. Shaima and Dr. Nada, for this very elegant event. And also I would like to say that we have been thinking about making something for the female gastroenterologists for some time, but they are the first ones to implement this and to make it happen in real world. So my topic that I was assigned to talk about is challenging hemostasis. And of course, GI bleeding is the gastroenterologist's nightmare. And when I was thinking, why is that? Because despite recent advances in management of GI bleeding, we still have high mortality rates that may reach up to 20% in acute variceal bleeding within the first 6 weeks and up to 10% in non-variceal bleeding.
دكتورة نانسي ادينا فرصة نقدم.
أنا آسفة معلش.
دكتورة نانسي فانوس من البوليس اوثوريتي هوسبيتالز هتكلمنا عن challenging hemostasis. بس انت دخلتي بقى بوليس من غير
لا أنا مش بوليس ولا حاجة.
أهلا بك.
تمام. Well, causes of gastrointestinal bleeding vary, whether upper GI bleeding, variceal or non-variceal, of which the peptic ulcer is the most common, and lower GI bleeding, of which diverticular disease of the colon is the most common. And when I was looking to choose what are challenging cases for hemostasis, I find that, as we see, almost all GI bleeding cases may be challenging. Also, the management of acute GI bleeding, from resuscitation to risk stratification, using the scoring systems to individualize the care of the patient, the pre-endoscopic management, the endoscopic management, and the secondary management are also challenging. So, over the last 3 decades, what improved our practice in managing acute GI bleeding? Is it the improvement in the quality of critical care? Is it screening endoscopy, the early use of vasopressors, the routine use of prophylactic antibiotics, the on-call endoscopy and interventional radiology services, the consensus, the new modalities, the training? So all these things helped to improve our practice in the last decades. My first case, I will present this case. This is a case of a patient, a 76-year-old patient. He has a liver cirrhosis post-HCV and was presented with two times of melena with hemoglobin drop from 10 to 6 grams per deciliter. The patient was scheduled for upper endoscopy, and we found that he has duodenal varices. And the decision was made to inject cyanoacrylate glue for the duodenal varices. Of course, duodenal varices or ectopic varices, the incidence is 1 to 5%. Well, I had the honor to participate with my mentor, Professor Ibrahim Mustafa, and my colleague Mustafa Ibrahim in writing the chapter in the textbook Gastroenterological Endoscopy that was published in 2018. And also I have went through the guidelines for the management of acute variceal bleeding. So regarding the timing of endoscopy, within 12 hours of presentation, and this is when to do endoscopy. What to do in endoscopy? Variceal ligation is the preferred method for esophageal varices and gastroesophageal varices type 1, whereas gastroesophageal varices type 2 and intragastric varices 1 and 2 and ectopic varices cyanoacrylate glue injection is the preferred method. APC, radiofrequency ablation with or without band ligation is recommended for portal hypertensive gastropathy and GAVE, whereas EUS-guided cyanoacrylate injection, coil deployment, or hybrid technique could be done in some centers nowadays. So this is what else can we do for gastric varices in cases of persistent bleeding or rebleeding within the first 5 days. Also, what else could be done? Some studies were done regarding the application of hemostatic powder in acute variceal bleeding, which showed significant improvement on the 6-week survival, which is the primary endpoint for clinical trials. So for the same case, this is another case, but this was presented with jejunal varices, but they were bleeding. And when this patient was presented, the patient was first shocked, and he was first resuscitated, and then the bleeding site could not be detected clearly due to the severe bleeding, and decision was made for application of hemospray, and this is the follow-up of the patient after 24 hours. So really some new modalities can help us in the management. Well, this is the second case of a non-variceal bleeding. This patient is a 47-year-old female patient who was on non-steroidal anti-inflammatory drugs for a long time, and that patient presented with severe hematolysis, melena, shock to the emergency. The patient was resuscitated, and the endoscopy for the patient was done after 8 hours, and it showed ulcer in the bulb of the duodenum with a visible vessel, for which hemoclip was done with successful hemostasis. So the timing of endoscopy in non-variceal bleeding is early within 24 hours, and this is the recommendation of the guidelines. Urgent endoscopy is not recommended as the outcomes are not improving. What is the management of peptic ulcer disease according to the ESGE? If we have an actively bleeding ulcer, first classification 1A or 1B. So what to do? Combination therapy is always preferred to monotherapy. Injection of epinephrine with combination of contact thermal or mechanical therapy can be done. If the ulcer is large, more than 2 centimeters, or with a large visible vessel more than 2 millimeters, we can use over-the-scope clip. In cases of a non-bleeding visible vessel, then contact or non-contact thermal mechanical therapy or injection of sclerosant agent plus or minus epinephrine could be done. If the patient has refractory active bleeding, then transarterial embolization or application of hemostatic powder or application of a over-the-scope clip can be used. This is the application of over-the-scope clip. Of course, I'm short of time, so I will skip this video. What about lower GI bleeding? The timing of colonoscopy in lower GI bleeding, here we see a meta-analysis comparing urgent colonoscopy less than 24 hours to elective colonoscopy more than 24 hours. Regarding the diagnostic yield, rebleeding, length of hospital stay, number of packed RBCs, endoscopic intervention, and mortality, and this was published in 2022 in the American Journal of Gastroenterology, and it clarifies that there is no significant difference in rebleeding or mortality, and accordingly, the patient with severe hematochezia and having ongoing significant bleeding and unstable, this patient is we scanned it for CT angiography. If extravasation was done, then embolization with interventional radiologist service or urgent colonoscopy can be done. If no extravasation could be detected or milder lower GI bleeding or the bleeding subsides, then non-urgent colonoscopy with split dose preparation versus observation could be done for this patient. As we said, the most common cause of lower GI bleed is diverticular bleed, which could be managed by band ligation, hemoclipping, and over-the-scope clip. Also, hemostatic powders could be used in lower GI bleed with excellent efficacy in initial hemostasis in the setting of post-polypectomy bleeding. So my take-home message is, while endoscopy is the gold standard, but initial assessment of patients, risk stratification, individualizing care, and achieving hemodynamic stability are the keys to better outcomes. The presence of an on-call GI endoscopist and supporting staff with technical expertise on a 24/7 hours basis is recommended. Always be ready and have a plan. Develop multidisciplinary team approach. Master your techniques, and always remember that in a fast-changing environment, no one is an expert all the time. You are an expert today and a learner tomorrow. Revise what you have done, what went well, what went wrong, and areas of future improvement. Our real impact is based not only on titles and recognition, but on how we cultivate kindness and enhance other people's lives, even in simple ways that are unrelated to our formal roles, and we always remember that. And thank you very much.
Thanks.